Endoscope in Gynecology, Professor Mahmoud Yosef Ali Ahmed Abdullah, Obstetric Gynecology Department, Faculty of Medicine and Shams University. Endoscope in Gynecology, Telescope, Light Source, LED, Halogen, Xenon. Camera. Distension media. A laparoscope is a thin, tube-like instrument with a light and a camera to look inside the abdomen or pelvis. The procedure is called laparoscopy. A laparoscope tower, also called a laparoscopy stack, is the central unit that supports visualization and instrumentation during laparoscopic surgery. It contains all the essential devices needed for imaging, light, insufflation, and recording. Components of a laparoscopic tower. Monitor, display screen. Displays the real-time intra-abdominal image from the camera. Light source. Provides powerful illumination via fiber optic cable to the laparoscope. Camera control unit, CCU. Processes the video signal from the laparoscope's camera head. Insufflator, CO2 insufflation unit. Pumps and regulates CO2 gas into the peritoneal cavity to create pneumoperitoneum. Suction irrigation unit. Provides suction and irrigation during procedures, optional. Electrosurgical unit, ESU. Delivers energy, monopolar or bipolar, for cutting/coagulation. Recording/documentation unit. Records images/videos for documentation and teaching. Power supply and cables. Powers all devices and connects components safely. Optional/additional equipment of laparoscope. Printer, for hard copy images. Smoke evacuator, clears surgical smoke for better visibility. Trolley/stand, modular unit to stack and transport equipment safely. Arrangement order, typical stack from top to bottom. Monitor, mounted or on top. Camera control unit. Light source. Insufflator. Electrosurgical unit. Recording device or printer. Irrigation/suction unit. Surgical instruments of laparoscope. 1 Varus needle. Used to create pneumoperitoneum by insufflating CO2 into abdomen safely. 2 trocar and cannula. Ports inserted into the abdominal wall to allow passage of instruments. 3 Laparoscope. Rigid or flexible tube with a camera and light source for visualization. 4 Graspa/forceps. To hold, manipulate, or retract tissues during surgery. 5 Scissors. For cutting tissues or sutures inside the abdomen. 6 Needle holder. For laparoscopic suturing and knot tying. 7 Suction/irrigation device. To remove fluids or irrigate the surgical field for better visualization. 8 Electrodes, monopolar/bipolar. For cauterization, cutting, and coagulation of tissues. 9 Clip applicator. To apply clips on vessels or ducts for ligation. 10 Specimen retrieval bag. To safely remove excised tissue or specimens from the abdominal cavity. Uterine manipulators. Uterine manipulators assist mobilization of the uterus. They are available as reusable or disposable devices. Electrosurgical instruments. Electrosurgical instrument for achieving hemostasis and should be tested to confirm that it is in working condition before surgery. Bipolar energy is most effective for hemostasis. It works by conducting electrical current between the jaws of the forceps. Newer bipolar devices have limited lateral thermal spread, lower contact temperatures, and greater mechanical compressive forces. In addition, some offer a concomitant tissue cutting ability. Monopolar energy, the electrical current is transferred through the device, and continued through the tissue until it finds the return electrode, often a pad located on the patient's thigh. Monopolar electrosurgical devices are often used to cut tissue, and sometimes for hemostasis. Compared with bipolar devices, they are associated with greater risk of injury, since the electrical pathway is longer, and presents an opportunity for direct or capacitive coupling. Harmonic scalpel uses mechanical energy to cut and coagulate tissue and vessels. It converts electrical energy into mechanical motion, resulting in vibration of an active blade at a rate of 55,500 Hz. An inactive blade acts as a backstop. This vibration causes the proteins of the intervening tissue to denature and creates a protein coagulum that seals smaller vessels. The mechanical secondary heat seals larger vessels. This process is performed at a relatively low temperature, 50, 100 C, reducing lateral thermal spread to surrounding tissues. Surgical lasers are also used in operative laparoscopy. The CO2 laser is usually used with irrigation fluid as a backstop to minimize the depth of penetration during cutting or vaporization. The thermal spread is limited to approximately 0.1 millimeters. Smoke evacuator. Tissue ablation using electrocautery is associated with smoke formation, decreasing visualization. This can be minimized by using an effective smoke evacuator. Suction, irrigator. A suction and irrigation device is necessary in laparoscopic procedures where bleeding is anticipated. Morcellator. Morcellators offer efficient removal of large volumes of tissue through small incisions, typically 12 to 20 millimeters. Staplers. Laparoscopic staplers seal blood vessels and cut tissue simultaneously. Depending on tissue thickness, a cartridge of variable length is inserted into the stapler device and applied across the tissue. The diameter of the shaft is usually 12 millimeters. 6 rows of staples compress the tissue and a blade cuts through the middle 2 rows, resulting in tissue separation with 3 rows of staples on each side. Vascular clips. Endo clips are useful for achieving hemostasis if the bleeding vessel can be visualized. And endoscopic loop. An endoscopic loop is useful for ligating pedicles or organs, such as in oophorectomy, salpingectomy, and appendectomy procedures. A suture loop with a slip knot is introduced, together with an applicator, through a 5 mm cannula. Typically, 3 loops are placed, followed by transection of the organ. Indications of laparoscope. Diagnostic indications. Chronic pelvic pain, when other imaging is inconclusive. Infertility evaluation, to assess tubal patency, endometriosis, adhesions. Pelvic mass of uncertain origin. Acute pelvic pain, to rule out conditions like ectopic pregnancy or adnexal torsion. Therapeutic indications of laparoscope. Ectopic pregnancy management. Endometriosis excision or ablation. Ovarian cystectomy. Myomectomy, for selected fibroids. Tubal surgery, example sterilization, or tuboplasty. Adhesiolysis. Hysterectomy, laparoscopic assisted or total. Treatment of pelvic inflammatory disease complications, example tubo-ovarian abscess. Radical surgery with lymph node sampling. Technique of laparoscopy in gynecology. 1. Preoperative preparation. Informed consent, labs, imaging as needed. Bowel preparation, optional, case dependent. Bladder catheterization. Prophylactic antibiotics. 2. Anesthesia. General anesthesia is standard. 3. Patient positioning. Dorsolithotomy with Trendelenburg position, head down tilt. Arms tucked, legs in stirrups, if vaginal access is needed. 4. Creating pneumoperitoneum. Varus needle or open, Hassan, technique. CO2 insufflation to create working space, under pressure of 12 to 15 mmHg. 5. Port placement. Primary port, 10 mm at the umbilicus. Secondary ports, 5 mm, usually in lower quadrants, under direct vision. 6. Diagnostic or operative procedure. Inspection of pelvic anatomy. Surgical procedure as indicated: adhesiolysis, biopsy, cystectomy. 7. Deflation CO2 released. 8. Port closure. Port sides closed, fascia for greater than or equal to 10 mm ports, skin for all. Dressing applied. Complications of laparoscopy in gynecology. Early, intraoperative, complications. Injury to blood vessels, example inferior epigastric, aorta, iliac vessels. Injury to visceral organs. Bowel injury. Bladder or ureteral injury. Gas embolism, due to CO2 insufflation. Anesthesia-related complications. Failure to establish pneumoperitoneum. Late, postoperative, complications of laparoscope. Wound infection or port site infection. Hematoma or seroma at port site. Adhesion formation. Port site hernia. Thromboembolic events. Shoulder tip pain, referred from diaphragmatic irritation. A hysteroscope is a thin, lighted tube used to look inside the uterus. It's inserted through the vagina and cervix during a procedure called hysteroscopy. Types of hysteroscope. 1. Rigid panoramic hysteroscope. 2. Office hysteroscope. Diameter of telescope 1.9 to 2.7 millimeters. The diameter of the sheath is 4 to 4.5 millimeters. 3. Flexible hysteroscope. 4. Contact hysteroscope. 5. Microcolpo hysteroscope, MCH. 6. Portable, self-contained hysteroscope. Lens angle. Rigid hysteroscopes have a camera lens angle of either 0 to 30 degrees. The scopes with a 30-degree angle allows visualization with minimal manipulation. With this angle, the hysteroscope can be brought to the midline of the uterine cavity and simply rotated about 90 degrees to the left or right with the light cord without much movement of the hysteroscope to visualize the cornu. With an angled hysteroscope, the image that is displayed on the screen is actually above the tip of the instrument. The scopes with a 0-degree angle would require manipulation of the entire hysteroscope to visualize the cornu of the uterus. This increases the patient discomfort. Components of hysteroscope. Outer sheath, cannula. Rigid tube that is inserted through the cervix into the uterine cavity. Provides a channel for instruments and fluid. 2. Optical system, eyepiece and lens. Contains lenses and prisms that transmit light and image from the uterine cavity to the surgeon's eye or camera. 3. Light source connector. Connects to a fiber optic cable that transmits bright light into the uterine cavity for visualization. 4. Working channel, operative channel. Allows insertion of instruments, example scissors, graspers, for operative procedures during hysteroscopy. 5. Distension channel. Allows fluid, usually saline, to flow in/out to distend the uterine cavity for clear visualization. 6. Camera attachment port. For connecting a video camera to transmit images to a monitor for better visualization and recording. 7. Obturator. A blunt or sharp stylet inserted into the sheath to facilitate safe cervical entry, then removed before inspection. Surgical instruments of hysteroscope. 1. Hysteroscope. Main instrument with optics and working channel for access. 2 dilators, Hagar or Pratt. Used for gradual cervical dilatation before scope insertion. 3 uterine manipulator. Helps position and stabilize the uterus during the procedure. 4 scissors, hysteroscopic. For cutting intrauterine adhesions, polyps, or septa. 5 grasper/forceps. To grasp and remove polyps, foreign bodies, or tissue samples. 6 resectoscope. For operative hysteroscopy, has an electrical loop to resect fibroids or polyps. 7 electrode, monopolar/bipolar. For coagulation or cutting using electrical energy. 8 biopsy forceps. For taking endometrial or lesion biopsy under direct vision. 9 fluid management system. Controls distension medium inflow and outflow during procedure. Indications of hysteroscopy in gynecology. Diagnostic indications of hysteroscope. Abnormal uterine bleeding, AUB. Postmenopausal bleeding. Infertility and recurrent pregnancy loss, to assess uterine cavity. Suspected intrauterine pathology. Polyps. Submucosal fibroids. Uterine septum. Adhesions, Asherman syndrome. Therapeutic indications of hysteroscope. Endometrial polypectomy. Submucosal fibroid resection. Adhesiolysis, treatment of intrauterine adhesions. Septum resection, metroplasty. Removal of retained products of conception. Endometrial ablation, for treatment of heavy menstrual bleeding. Removal of foreign bodies or IUCD. Indications of vaginoscopy in virgins, or prepubertal girls. Vaginoscopy is a non-traumatic, speculum-free endoscopic examination of the vaginal canal, especially useful in virginal or pediatric patients where conventional speculum examination is inappropriate. Common indications. Unexplained vaginal bleeding. Suspected foreign body. Congenital anomalies of the vagina or hymen. Vaginal discharge or infection not responding to treatment. Evaluation of vaginal or cervical lesions. Assessment of trauma or abuse, in a sensitive, forensic context. Persistent lower genital tract symptoms, pain, itching, etc. Vaginoscopy allows direct visualization with minimal discomfort and is especially useful in preserving hymenal integrity. Distension media. For many years, carbon dioxide, CO2, was the distension medium classically utilized for diagnostic hysteroscopy. It has the same refractive index as air, 1.00, providing clear images of the endometrial cavity. The use of CO2 has disadvantages. Bleeding of the endometrial walls after simple contact with the hysteroscope and creation of gas bubbles. The inability to remove the blood and the mucus resulted in the restriction of the optical field. The problem of carbon dioxide gas was confronted with the invention of continuous flow and irrigation hysteroscopes as well as with the use of liquid solutions with low viscosity, such as normal saline, NaCl. The easy availability, the low cost and the safety provided by normal saline for diagnostic hysteroscopy allowed the expansion of its use on an outpatient basis. The use of solution, Hiskin or glycine, saline. Normal saline, NaCl has a refractive index equal to 1.37, more than that of the air, 1.00, resulting in magnification of the area under examination. Electrodiathermy in hysteroscope. Bipolar. Distension media and electrolyte-rich medium, such as normal saline, higher fluid deficit, 2,500 ml for healthy patients, 1,500 ml for elderly patients or patients with comorbidities. Isotonic media are miscible with blood. A potential drawback is that in cases with bleeding. Monopolar. Non-electrolyte distension media, a hypotonic, a poor conductor, such as glycine 1.5%, mannitol 5%, or sorbitol 3%, the fluid deficit is limited to 1000 ml, fluid deficit of 750 ml for elderly or fragile patients. Hyponatremia, hyperglycemia, life-threatening cerebral edema. Glycine use is contraindicated in patients with renal or hepatic failure. If there is damage to electrode insulation, risk of current diversion to the cervix, vagina, or vulva. Good visibility is maintained even when encountering bleeding. Technique of hysteroscopy, diagnostic and operative. Hysteroscopy is a minimally invasive procedure used to inspect and treat intrauterine pathology. Here's a step-by-step guide to the technique. Patient preparation. Consent. Obtain informed consent. Pre-procedure evaluation. Rule out pregnancy, active infection. Timing. Best performed in early proliferative phase of the menstrual cycle. Pre-medication. NSAIDs for pain. Misoprostol may be used to soften the cervix. 2. Positioning lithotomy position under local, regional, or general anesthesia. 3. Aseptic preparation, clean vulva and vagina with antiseptic solution. 4. Cervical access, use a vaginal speculum to visualize the cervix. Grasp anterior lip with a tenaculum if needed. Gradual cervical dilatation may be required, especially for operative hysteroscopy. 5. Insertion of hysteroscope. Insert hysteroscope gently through the cervix into the uterine cavity. Types: rigid or flexible hysteroscope, diameter usually 2.7 to 5 mm. Use continuous flow for better visualization. 6. Uterine cavity distension. DIST ending media. Normal saline or CO2, saline preferred for safety and visibility. Monitor pressure, usually 80 to 100 mmHg for saline. 7. Systematic cavity inspection. Visualize internal cervical OS, endometrial cavity, tubal ostia. Look for polyps, fibroids, adhesions, septa, or malignancy. 8. Operative procedure. If indicated, insert instruments, scissors, forceps, resectoscope, laser, etc., through operative channel. Perform polypectomy, myomectomy, adesilysis, extraction of IUD. 9. Completion. Remove instruments. Assess for bleeding or complications. Document findings with images/video if available. 10. Post-procedure care. Monitor vitals, manage pain or bleeding. Antibiotics if indicated. Patient can usually go home the same day. Advantage of the vaginoscope. Vaginoscopic hysteroscopy with either a 2.9 mm or a 4 mm 30 degrees scope is significantly quicker to perform than the traditional technique, independent of the reproductive status of patients. Vaginoscopy is associated with less pain than traditional hysteroscopy during passing through the internal cervical OS. Vaginoscope allows inspection of the vaginal walls in addition to the uterine cavity. Vaginoscopy can be extremely helpful for evaluating patients who are morbidly obese and for whom standard office instruments are not adequately sized for visualization of the cervix. Vaginoscopy is effective, fast, and easy for managing gynecologic problems in pediatric and adolescent patients. Most of the time, patients leave the office within 15 minutes, after checking their vital signs, so happy to have had their procedure done in the office as opposed to the hospital. Technique of office hysteroscopy, performed without general anesthesia in an outpatient setting. 1. Patient preparation. Consent, explain procedure, risks, and benefits. Timing, early proliferative phase of the cycle is ideal. Pre-medication, optional NSAIDs, example ibuprofen, misoprostol, to ease cervical entry. 2. Patient positioning, lithotomy position. No need for general or regional anesthesia, local may be used if needed. 3. Aseptic measures, clean vulva and vagina with antiseptic solution. Sterile draping. 4. Vaginoscopic approach, preferred in office setting, No speculum or tenaculum. Insert hysteroscope directly into the vagina and navigate to the cervical canal gently. Reduces discomfort and improves patient tolerance. 5. Insertion of office hysteroscope. Use a slim, less than or equal to 3.5 mm, flexible or rigid hysteroscope with continuous flow. Insert slowly through the external OS into the endometrial cavity. 6. Uterine distension medium, normal saline via a gravity system or pump. Maintain pressure around 50 to 80 mmHg. 7. Systematic cavity evaluation. Inspect cervical canal, endometrial lining, uterine walls, tubal ostia. Look for pathology, polyps, fibroids, adhesions, malformations, etc. 8. Minor operative procedures. If needed, use many instruments via a working channel for biopsy, polypectomy, adesilysis. 9. Post-procedure minimal observation time. Discharge with advice on spotting or cramping. Explain findings and follow up if needed. Complications of hysteroscope. 1. Mechanical injuries. Uterine perforation. Cervical laceration or false passage. Injury to surrounding organs, rare, but possible if perforation occurs. 2. Fluid-related complications. Fluid overload, hyponatremia or hypoosmolarity, especially with glycine or sorbitol, pulmonary edema. Air or gas embolism, rare. 3. Infection. Endometritis. Pelvic inflammatory disease, PID. 4. Hemorrhage. From uterine trauma, vascular lesions, or operative procedures. 5. Anesthesia-related complications, especially in operative hysteroscopy under general or regional anesthesia. Study endoscope in gynecology.